Okay, it looks like everyone's here, so we're going to get started. Good afternoon and welcome. My name is Amanda Lee, and I'm the Rate Setting Coordinator for the Office of MaineCare Services. I'm hosting today's call along with several of my colleagues at the department. Jessica Levesque will be my co-host, and she will be assisting with logistics, and she'll take over if I have any technical difficulties. We'll get to introductions in just a moment. But first, I wanted to go over a few details about the forum. This is our third annual rate determination schedule consultation. So for those joining for the first time, I just wanted to share the intent and flow of today's forum. So the department will present the draft schedule for initiation in calendar year 2025 in order to accept feedback or advisement from the technical advisory panel. After that, we will move on to public comments, and I will go over how to make a public comment at that time. But for now, to prevent any interruptions during the presentation, all participants are in listen-only mode, and the chat function has been disabled. Participants may only chat with myself or the co-hosts. And if you do try to chat me, it might be best to just chat Jessica Levesque, as I won't be able to get to you immediately. I'll be running slides. This forum is being recorded in its entirety, and it will be posted along with the presented materials by the end of today at the Rate System Reform webpage, which we will link into the chat. A notice will go out on Monday with those links, along with instructions for submitting written comments. And yeah, we appreciate everyone's participation today and look forward to hearing your additional comments. I'll hand things over to Michelle to get us started.
Great. Thank you, Mandy, and welcome everyone this Friday afternoon. In order to get started, first we will do introductions. So this is the technical advisory panel, and thanks for those of you able to join. And I can go through and call names, and you can introduce yourself and the organization that you're from. So first, I'll start with Marty. Did you hear me, Marty? Or are you able to unmute?
You have to unmute. Hold on.
Oh, sorry, that's slow on our side. Apologies.
Marty should be all set to.
Okay, yeah, it kept telling me the host had to, or whatever. So I am Marty Hooper, the Life and Health Actuary for the Maine Bureau of Insurance.
Great, thank you. Is Heather Hyatt with us today?
No.
She's not able to. Okay, so Heather Hyatt is the Associate Director of Community Health Programs with the DHHS Division of Licensing and Certification. She's not able to be here today. We will go to Meg.
Great. Hi, Meg Garrett-Reed. I am the Executive Director of the Office of Affordable Healthcare, an independent state agency that's part of Maine government. Thanks.
Great. Thanks, Meg. And Mark.
Good afternoon, Mark McInerney. I'm the Director of the Center for Workforce Research at the Maine Department of Labor.
Thank you, Mark. And Amanda?
Okay. Good afternoon. I'm Amanda Rector. I'm the Maine State Economist in the Department of Administrative and Financial Services.
Thanks, Amanda. And I don't see Karen Lee Harrington unless she's hiding somewhere. Karen Lee, are you out there?
I am.
There she is.
Good afternoon, everybody. Karen Lee Harrington with the Maine Health Data Organization and the Maine Quality Forum.
Great. So thank you, everybody, for being here. First up, well, I guess before we go to the agenda slide, I'll just say a few things off the top. It's great to convene this group again and to discuss the progress that we continue to make on MaineCare rate reform, especially in terms of making it through, or making progress and making it through all of our services to make sure that they are reasonable and adequate and help to encourage high value care. I'll just acknowledge that this season feels different from the past couple of times that we have convened, and different from when we first were able to see unanimous passage of our rate reform law in the legislature in the summer of 2022. Rate reform over the past few years has become somewhat synonymous with rate investments. That hasn't been universal across the board, but it has provided a great opportunity to reassess services that sometimes had not been fully assessed in a very long time. And also that work coincided with important work to make sure that our reimbursement was adequate to help support hopefully living wages, I guess I'll say, for direct care workers as well. And so while we were approaching this budget season and we're talking a lot about the MaineCare shortfall that we were projecting and how to proceed, more than once I was asked, oh, does this mean the end of MaineCare rate reform? Is MaineCare rate reform done? Are we going to be repealing that statute? And I said, no, it is not done. No, we are not repealing the statute. It is a different context, but reform is still important. For one, there are still services that do require investment. And even if we do not have the resources at this time to invest in those services, having a transparent process where we determine what reimbursement should be is still important to inform a time when we are able to invest. And then I will also say that rate reform, reimbursement reform also involves difficult decisions. And we know that there are parts of our system that may be reimbursed more generously than others. There are parts of our system and services that have reimbursement methodologies that are inadequate in terms of the incentives that they provide for cost control and quality. There are parts of our system that still result in a lot of variation that I would say is not very defensible across providers. And so there is opportunity, and sometimes constrained resources can actually present opportunity to make reforms that are in the interest of our broader principles of rate reform. And so you will see a little bit of that today. Also, I think it's fair to say I've heard from many states nationally that struggle with, as we have and are, struggle with the fact that it makes good economic sense that as costs rise, that reimbursement should rise accordingly. And we believe, which is why we put it into our rate reform statute, that adjusting rates for cost of living increases makes sense. And that when we are, and so for reimbursement that is benchmarked to sources such as MaineCare, we update those as MaineCare updates their reimbursement to take into account changes in cost, et cetera. And that for the rates where we are setting ourselves, where we are not doing a full-scale rate determination every 5 years, and on the off years, we adjust for inflation as well. We continue to believe that that is the right thing to do. However, I would really say that we are making a clarification with one of our budget initiatives, Part UU, that really acknowledges the fact that is pretty simple, which is that if there are not available appropriations, then we cannot make investments. But rather than strike the law to say, oops, we changed our minds, we don't think that annual adjustments are the right thing to do anymore, the language just acknowledges the fact that we will make those adjustments when there are available appropriations. But if there are not, then the only way that we could proceed with those adjustments would be to deepen a potential shortfall and create more problems. So it was a hard decision and one that we talked a lot about, but again, really felt it was important to maintain the principles and process and transparency of our rate reform law, but also acknowledge the broader economic realities. So that's my attempt. I probably already talked about a few of the slides that I was supposed to talk through, but that's kind of the context that we're in more broadly. And I'll also just acknowledge that this session is later than we ideally would have had it, and later than it has been in the past couple of years, in part just because these discussions around, what are we able to proceed with in terms of rate reform, and what initiatives do we need to put on the table to balance the budget, how that interacted with our rate reform objectives. So this is where we get consultation from the TAP, and we will proceed to hear from our MaineCare Advisory Committee as well. And as always, we acknowledge that things change. They always do over the course of the legislative session, and as needs ebb and flow over time. So there will be opportunity to adjust as we go forward. All right, Mandy, if you or Jessica, I'm not sure who is sharing the slides, but if you could pull them up, that'd be great. And you can go through to the agenda slide. Okay, so specifically, I will talk a little bit more about our rate reform law, goals of our rate determination schedule, and what that, we'll talk about what that timeline looks like. We will look back at the past year and outline the progress that we made on the schedule that we discussed for calendar year 24. And then we will be getting into the proposed draft calendar for calendar year 2025, including highlighting where there is associated legislation. And then lastly, providing an overview of the services within MaineCare that have not yet gone through that kind of baseline rate determination. And with that, we will stop the presentation and take questions and comments from the TAP. Okay, next slide. So we just went through introductions for our TAP members, so thank you for that. And next.
Michelle,
Okay.
sorry to jump in. Can we do introductions on the MaineCare side quickly?
Oh, that's a great idea. Thanks, David.
Sure thing.
Sorry. I'll hand it to you first.
Great. So I'll ask anybody with a speaking role on the MaineCare side to introduce themselves. On my part, my name is David Jorgensen. I'm the Associate Director of Data Analytics and Rate Setting for MaineCare. And I will pass it over to Olivia.
Good afternoon. I'm Olivia Alford. I'm the Associate Director for Delivery System Reform at MaineCare. I need to know who else is speaking.
Jessica Levesque.
Hi, I'm Jessica Levesque. I am a rate reform project manager at MaineCare Services. Mandy?
Amanda Lee, Rate Setting Coordinator for the Office of MaineCare Services. I think that's it.
Great.
All right,
Thank you.
Great. And thanks, David, for that reminder. All right, so our rate reform law, I already mentioned, was enacted in 2022. The official citation is MRSA 223173J. And it really codifies the process as well as the principles for MaineCare, for our MaineCare rate system, which really relies on the importance of transparency, of really getting input from providers and interested parties locally, as well as making sure that we are taking advantage of benchmarks and relevant data on a state and national level. And then this group that brings to the table, the technical advisory panel that brings to the table expertise around different components of healthcare as well as broader economic drivers within the state. So first, and really, you will hear Governor Mills from time to time speak to this fact. It was for many years the truth that the schedule, we'll call it, for review of different rates was largely related to advocacy from different groups and from the legislature. And as a result, there were some rates that were updated fairly regularly, and there were other rates that would go years and sometimes over a decade or more without adjustment. And so one of the main principles of MaineCare rate reform is that there needs to be a schedule for regular rate review and adjustment. We prioritize alignment with Medicare. In most cases, that is appropriate. There might be some exceptions. We also are open to other appropriate benchmarks from other sources for reimbursement. And part of the rationale there is that when there is an existing process, especially with a process like with Medicare that is based on more robust data and resources, that it makes sense and helps leverage the combined power of Medicare as well as MaineCare around that reimbursement. So as I noted earlier, those benchmark rates get updated for Medicare every year. And then if and when we are looking at other payers, just because that's a little bit more time intensive, we would make those updates every 2 years. And then we have a number of services that may be more unique and where there might not be rates that we can benchmark. And that is where we really do full scale rate studies, rate determinations. And so that is really what this group reviews and our, well, no, that's not true, actually. I'll say that when we put on the rate reform schedule rate determinations, it can be both to look at benchmarks or to do rate studies. And for services that have rate studies, the law requires that we update the determination of those rates every 5 years, sometimes called rebasing. And as noted earlier, when we are not rebasing a rate, then current law states that those services will receive annual cost of living adjustments. I already noted that the law makes sure that we are reviewing relevant state and national data, and that we have a process that includes public notice, presentation, comments, also establish the rate system subcommittee of our MaineCare Advisory Committee in addition to this body. Next slide. Okay, so as I highlighted at the top, in the budget proposals put forward by the governor this year, Part UU, some of you may have heard of, is related to changes to, there's a few pieces of statute, but all of them are related to MaineCare reimbursement. And the first thing that these changes really aim to do is to provide more consistency across the MaineCare portfolio and consolidating different parts of reimbursement that relates to statute under our rate reform statute. So that includes some statute that is specific to nursing facilities, a statute that is concerning rate adjustments for services where there's the requirement that rates be adequate to support 125% of minimum wage for essential workers. And so we're kind of making that easier to find and more consistent in one place. As I also noted, recognizing the reality of the fact that state budgets, especially in regards to Medicaid, do fluctuate. This is really a clarification that in order to make these adjustments, we do require available appropriations. The statute already indicated that the state would be able to access the MaineCare Stabilization Fund if there were not otherwise adequate appropriations for a rate adjustment. This just offers or puts forward the clarification that using dollars from the MaineCare Stabilization Fund is really a one-time stopgap measure that is a short-term solution. And in order to continue to support rates at an adjusted increased level, there still does need to be an ongoing appropriation to do that. In addition, we often there's a lot of work that goes into predicting what COLA indexes are going to be before we actually have that information. The general rule is that you're always wrong. And so in the past few years, we've had to go through a process where we've predicted what we think COLA may be that applies to a number of services. Then the actual inflation ended up being higher. And so then we need to ask for more dollars in order to then retroactively increase the rates. And so this Part UU change language also includes changes that provides for a bit of a lag that basically allows the state to have predictability and accuracy, knowing what index is going to be, and then having time through the budget process to apply that. And lastly, the item I wanted to highlight is that this also explicitly permits the department under the Administrative Procedures Act to incorporate reference to reimbursement benchmarks. So incorporation by reference under the APA is not, there's interpretation that is not necessarily allowed. And so we wanted to make that clear for MaineCare rate reform that benchmarking, for example, MaineCare and other state Medicaid agency rates is allowable. All right. And I think with that, I will hand it to Mandy.
Thank you. Sorry, it took me a second. So per rate reform law, on an annual basis, we will consult with the rate reform technical advisory panel on our draft schedule recommendations for the coming year. After the consultation, we will share the proposed schedule to our public website, which was shared in the chat earlier, and then provide opportunity for public review and comment. We'll post a summary of all comments to our webpage, and then we will conduct off-schedule rate determinations as the department finds appropriate. And then here we have the finalization of the rate determination schedule timeline. So on January 21st, we posted the draft rate determination schedule and sent a notice of that posting. Today, we're consulting with the technical advisory panel, presenting our recommendations for calendar year 25. And then March 24th, the MAC rate reform subcommittee will meet to discuss the schedule. And then from there, they may formalize any recommendations to present to the full MaineCare Advisory Committee. The deadline for public comments will be April 25th. And then we will post a summary of all comments online for rate reform law on the week of May 1st, along with the final rate determination schedule. Jess?
Yeah, I'm sort of delayed there with the unmute. Thank you. So this is a sample of the rate determination process and how it starts out and how it ends in rulemaking. So we start out with a service delivery model, definition or design work, and then there's internal planning, which includes research and analysis. Then there's the vendor procurement process. We'll do an initiation notice that gets sent out to the sections of policy that are applicable. We do kickoff meetings, internal and external, which we send another notice at the time of kickoff so everybody's aware of it. And there's a period of data collection, and then we work on finalizing the draft rates. rate models so that we can then present those draft rate models to the public. Then there's a period of time in which we accept public comments. Once we receive the public comments, we will review them. We have written response to the public comments posted on our rate reform website. Then we finalize the draft rates once we've been able to review the comments and determine if we're going to make any changes. Then the rates will be implemented, and then the rulemaking process will go through its period of time.
Great, thanks, Jess, for walking us through that, and hopefully that gives you all a little bit of a sense of what our process looks like for the rate determinations we've completed and what we're considering for the CY25 schedule. To reflect what we have worked on over the past year, Mandy, if you could advance, we'll walk through some of the rate determinations that have been completed, as well as some that continue to be in progress. We have completed rate determinations for a couple services in Section 23. This included adding a new service, comprehensive health assessments, and updating the rate for an existing service. These services are critical for youth entering foster care, and that was an important pair of services that we were able to update through our rate determination process. Next, with hospitals, this phase of hospital reform really focused on acute care hospitals, rehabilitation hospitals, and critical access hospitals. And among acute care and rehab hospitals, we have updated the reimbursement methodology for inpatient reimbursement to align more consistently with a DRG-based payment approach, and we've updated our DRG weights to align with Medicare DRG weights. We also included investments into increasing the base rates for those DRG weights, so that that reimbursement hadn't been looked at in likely a decade. So it was important for us to look at increasing those that reimbursement on the facility side. With outpatient reimbursement, we also moved towards standardizing to 109% of the outpatient APC, the Medicare APC payment, and that was also a new investment into those services. For critical access hospitals, to reflect the fact that critical access hospitals would be exempt from the hospital tax, we adjusted their reimbursement methodology to go from 109% of cost to 104.5% of cost. Next, another new service or a new service model, our certified community behavioral health clinics have just been initiated or implemented this month. We went through a rate determination to stand up this new model, which will be a new way of delivering and reimbursing for behavioral health services. Next slide, please. So for nursing facility reform, this has been quite a long effort to make sure that we could rebase and revise how we set our nursing facility rates. A lot of work went into engaging with nursing facilities and doing a lot of research on how to improve the way that we reimburse for nursing facilities. Those rates were able to go live in January. Some features of this reimbursement reform were to shift our reimbursement away from a cost-settled approach, so that direct care and routine rates would no longer be cost-settled for nursing facilities. This allows us to set a price at the beginning of the year to announce those rates on a fee schedule and give a lot more predictability to the department and to the providers on what reimbursement would be, so that the cost settlement process doesn't lead to any uncertainty about what that reimbursement will be. Let's see, for certain family planning services and long-acting reversible contraception, there was an acknowledgement that we needed to update some of this reimbursement. These are services that often don't have Medicare rates. For the ones that we did, we moved those to 100% of Medicare, and for the ones that don't have Medicare benchmarks, including reimbursement for the long-acting reversible contraception, we updated our methodology to be able to increase those rates to more closely align with the wholesale acquisition cost of acquiring those pharmaceuticals. So for children's therapeutic foster care and therapeutic intensive homes, this was another scenario where we were updating one existing rate and also adding a new reimbursement rate for a new service model. These services are, again, important for youth in foster care and for their providers. This allowed a pretty significant increase to the existing therapeutic foster care rate with additional investment in the new service model that's a more intensive service model. And lastly on this slide, we have just completed the rate determination for psychiatric residential treatment facilities, PRTFs. This service model is an additional level of care in inpatient behavioral health treatment. It is less intensive than a hospital admission or a psychiatric unit admission, and is really focused on services for youth under 21. This section of policy has been in existence with MaineCare for quite some time, but reimbursement was obsolete, and we have had no providers enrolled in this model previously. We're hoping with this updated reimbursement rate, as well as with some additional funding that the Office of Behavioral Health is able to provide, we'll be able to attract providers to be able to provide this level of care. And then lastly, for other rate determinations, we've completed, this was actually a benchmark assessment, not a full rate determination. Last summer, we completed the benchmark assessment for dental services. As a result of that assessment, we identified that most of the rates, to continue with the existing methodology, many of the rates would have decreased. So we have shifted away from using those benchmarks. We kept rates flat to avoid those rate cuts, acknowledging that these are services where access is a significant issue at the moment, and we would be looking at conducting a more complete rate determination in the future to be able to identify a new methodology. All right, and now Mandy can provide some updates on some rate determinations that are in progress.
David. So yeah, as you can see on this slide, there are several in rate model development phase. Palliative care, OMS and its vendor are working with the National Academy of Health Policy, NASHP, on a service model cost analysis, and use that analysis along with staffing surveys to inform the development of the rate model. Opioid health homes, it includes a new model for substance use disorder. That work was started. It allows for additional substance use disorder services within OHH model, and we are still working on that model. For home and community-based services and the new lifespan waiver, draft rate models are being reviewed. We hope to present for public feedback within the next couple of months. And then for psychiatric hospitals, for IMDs or institutions for mental disease, that one is in data analysis, and we will be requesting updated data from those providers. For Section 30 family planning and the new alternative payment model, that's in rate model development. We did present the draft rate model and are reviewing comments and plan to have additional stakeholder engagement after initial review of the model by CMS, which began in January. Sorry about that. And then Section 97, Appendix C, residential care facilities. This one's in internal planning. We originally kicked this off with the nursing facility reform work. We met with interested providers and parties and gathered information from them on specific topics. And then in coordination with the Office of Adults with Disabilities, we made the decision to prioritize the NF reform before continuing with RCF reform. For mobile crisis response teams, this one is in comment phase being reviewed. The rates are being finalized, and we plan to hold another public meeting to discuss revisions. For Chapter 6, Section 3, Primary Care Plus, we're kicking this off publicly with interested parties in the next couple of months. And for paramedicine, also in rate model development, we are continuing work with interested parties to determine requirements and best practices for this model. And home and community-based services for the sections and services noted here, there's several. Our vendor continues to review survey data and other interested party feedback to develop that draft rate model. Interpreter services under Chapter 1, Section 1, we will be kicking that off on March 31st publicly and sharing a timeline. And then Section 80, pharmacy dispensing fees. This was a mid-year addition to last year's schedule. We're participating along with several other New England states in an initiative through the New England State Consortium Systems Organization, also known as NESCO, to develop a reimbursement methodology for dispensing fees, pharmacy dispensing fees. Survey data has been compiled and they are analyzing, it's being analyzed by the vendor. Back to you, David.
Thanks, Mandy. So for these services, we'll be talking in a little bit more detail in future slides. So I'll cover at a high level. Some work has started on these models for service model assessment with our sister agencies. The Office of Behavioral Health has been working on the coordinated specialty care model, and the Office of Behavioral Health has also been looking at PMIEs, and the Office of Aging and Disability Services has been looking at PMIFs. We've along with the Office of Behavioral Health, OBH, we've conducted a number of site visits to PMIEs to understand the service models and what's working, where the challenges are. And then for both of these PMI models, we have a draft RFP in progress to continue doing that service model assessment with some additional vendor support. And then we would, once we get through that phase of service model assessment, we would work on the rate determination itself after that point. All right, and then some of these rate determinations were not on the original CY24 schedule that we had developed in consultation with the TAP. This slide indicates what services were added on. So I mentioned the Section 23 child abuse evaluations. We did this in recognition that we were already doing a rate determination on the child health assessments in Section 23, and it would be more efficient for us to just complete the rate determination for the entire section of policy at the same time. So we pulled in the existing service as well to make sure that we could have those updated at the same time. For the family planning and LARC initiative, that was a budget initiative that was added to the budget last spring, so that we took that work on for temporary high intensity staffing services in PNMID. This is an area where there have been additional access issues with provider feedback. We identified that that work in this area was merited. And so we initiated this rate determination late in 2024, and more recently completed that rate determination, or we're about to complete that rate determination currently. For the Section 80 pharmacy dispensing fees, we were presented with an opportunity through a partner organization, the New England States Consortium, I forget the whole acronym, NESCO, has been conducting a study of pharmacy dispensing fees among New England states, and we were able to join that initiative to piggyback on that work. And that work is just in the development phase right now. And lastly, these rate determinations were on the CY24 schedule. We have published an RFP and are still working through contract negotiation. So we have not yet initiated a rate determination for the school-based services and the MDFT services, but the work is underway and will be initiated when that contract negotiation is complete. All right, and now we will transition to looking at our proposed rate determination schedule, and I will turn it over to Michelle to talk through some of the goals that we prioritize when we're developing this schedule.
Great, thanks, David. So this slide, as David said, overviews some of our goals, the rate determination schedule, and criteria we take into consideration when setting that schedule. And these criteria have been consistent for the past few years and will remain so. One is we are still going through all MaineCare services to make sure that they have rate determinations on the record under this statute. That's a process that we are still going through. And then again, once a service has had those kind of baseline rate determinations, then it will go into a schedule for whether it's the annual updating through MaineCare or 5-year rate rebasings. We do have a goal that sometimes there, or oftentimes, there are like services that cross multiple sections of MaineCare policy, and when that happens, we prefer to conduct that rate determination together. That's why sometimes you'll see like 2 sections of policy involved in a rate determination. So we're trying to be efficient and consistent. And then the last two bullets there, we actually added these to our proposed amendments to the rate reform statute, just to call out specifically that as funding may not always be sufficient to do all the rate determinations, or I should say implement all the rate determinations we would like to, we are now calling out that if there's a service that has not yet received a rate determination, or if there's a service where we know that there is evidence of member access issues, that those are two criteria that the department should use to prioritize not just the rate determination schedule, but also availability of resources to implement those rate determinations. So as I noted in my introductory remarks, and you can go to the next slide, the context this year with the MaineCare shortfall has added some additional criteria that we've taken into consideration for this proposed calendar year 25 schedule. As I noted at the outset, it presents an opportunity to look at areas where rebalancing makes sense, and while also maintaining the principles of rate reform. And so, again, those principles include better alignment with MaineCare, making sure that we're improving equity across providers, that there are incentives for cost control, and that reimbursement includes benchmarks for reasonableness of the costs that reimbursement is associated with. Again, prioritizing rate determinations for areas where needs have been escalated or where we know of member access issues, and just clarifying here that we're trying to be more clear going forward that if we conduct a rate determination process, we are committed to that transparency and the fact that it is helpful to have a determination of what reasonable and adequate rates are. However, that process is separate from actual implementation, and that we need an actual appropriation to be able to implement those rate determinations. Sometimes we are able, those two pieces are able to come together where we are conducting a rate determination process and we know we already have funding available to implement, but that is not always the case, and we are still committed to making sure we go through rate determinations for the full catalog of MaineCare services, regardless of budget status. All right, David, back to you.
Sorry, I thought I unmuted. Thanks, Michelle. These next couple of slides are intended to give you some idea of the costs that MaineCare sees programmatically at a very high level. So Michelle made reference to COLAs previously. Many of our COLAs are tied to minimum wage, especially what we refer to our Part Quadruple A services. Those are services that where the providers include essential support workers, and we are required to set our rates in a way that the labor components of those rates equals at least 125% of minimum wage. So, this index, the CPIW index, is the index that our Department of Labor uses to determine minimum wage adjustments every January. So for our COLAs, tracking this index is important. You can see this index was growing very rapidly during COVID. It has leveled out a little bit since then, but still has a fairly rapid rate of growth. Maine's minimum wage has increased by 16.5%. from 2021 to 2024. And for those minimum wage increases, MaineCare was able to provide COLAs to match those adjustments for those Part Quadruple A services. Next slide, please. All right, this slide gives a sense of scale for how much spending is associated with our different sections of policy. Almost a third of our spending is associated with hospitals and nursing facilities. Other large areas of spending include our HCBS waivers, our pharmacy services, and our behavioral health services. I think that's good for this slide. Let's move on to the next. Another way that we look at spending within the MaineCare program is on a per member per month basis. This trend gives you a sense of MaineCare spending for different eligibility categories. And you can see that we tend to spend more money on people who are enrolled under aged or disabled enrollment category, and we spend less money on children, adults who are enrolled under a more traditional Medicaid enrollment and our expansion population. Next slide, please. And then I just wanted to call out that all of our rate determinations that we've talked through and ones that we're planning for this year have legislation associated with them, either to require us to do these rate determinations or to provide the funding to be able to actually implement those rate determinations. Some of these are proposals coming up are still with the legislature for consideration in the current budget, but there is quite a bit of existing legislation for us to reference for our prioritization. Right, coming to the meat of our proposed rate determination schedule, we will be continuing rate determinations that are in progress that we've already initiated. I mentioned for hospitals, our initial phase was for acute, rehab, and critical access hospitals. We also have psychiatric hospitals, IMD hospitals, and we need to look at their reimbursement as well. We are continuing work on a family planning APM. There's additional work. Mandy mentioned a new forum on crisis within the near future. And we will be continuing the work on HCBS services, both in this nursing and clinical services section and the other services corresponding with the lifespan waiver study. The community paramedicine work is also ongoing from the CY2024 schedule. Let me see. I'm gonna move through these quickly. I will just call out interpreter services because we haven't talked through those before. That was a priority from the previous rate determination schedule that is still underway. And these are, we talked about PMIEs and Fs for service model design, and we talked about coordinated specialty care. We'll get into a little bit more detail in those in the next slides. And then for new rate determinations to be initiated, We also talked about MDFT and school-related services for Section 106 that will be initiated when the contract negotiations are through. And then for consideration in this budget, we've proposed some proposals around ambulance services. Those would be tied to a ambulance provider tax, doing Medicare standardization for lab services and hospice services, and then looking at adjustment to our hospital professional cost settlement service. I'm going to hand things over to Olivia to get into a little bit more detail.
Thanks, David. I'm actually going to go quickly so we make sure we save time for comments from the group. So you've heard a lot about the reasons why we're continuing service model design for PNMI's Section E and F with our partner offices. So I'm going to move forward, the next slide, through those two. So coordinated specialty care, you might more commonly hear of this as first episode psychosis. So again, it's an area where we've been working on with the Office of Behavioral Health to define this service model. It's currently paid for via general fund, and I'm sure other models elsewhere. They've been doing, or we collectively have been doing, work looking at other state examples, fidelity models, and tools and technical assistance from the federal government to make sure that we get this service model right before moving into a rate determination calculation. So that's exciting work. Next slide. David just did a nice job explaining multidimensional family therapy. There's a service definition here, which I'll just give folks a few seconds to read it if they want to know more about that. But part of the Children's Behavioral Service Plan for the department to add this service to our continuum. Next slide. David also gave an overview of how really there's a vendor that will do both the rate determination for and multidimensional family therapy, and then also school health related services. And when we say school health related services, we already cover many of those and have rates for them, but this will be looking at new early development services, certain school nurse services, and services by school psychologists specifically. So there is ongoing work in this area, but this is an additional level of rate determination for some new services related to this forthcoming. Next slide. All right, so these next four are the items that David had called out that do have an intersection with budget initiatives within the biennial budget. But again, there is sometimes a direct interaction with those initiatives and the rate determination schedule, but other times they may exist in isolation. So we have our section, our ambulance services rate determination proposal, which will look at, which coincides with the proposed budget initiative that proposes to leverage federal dollars through an ambulance service assessment. And again, that's under review and subject to some kind of interaction depending on how that lands. Next slide. Laboratory services, similarly, historically, when MaineCare had first standardized to Medicare, there were instances where under laboratory services, the adjustment to the standardized rate was going to cause a reduction in service, reduction in rates, and at that time was not implemented. However, this initiative would implement full standardization for those services that have a Medicare benchmark to the 72.4%, along with the other services that are already at that benchmark. Next slide. This effort is to address an area of hospital reimbursement that has not been addressed in the other areas that David and others previously outlined. This initiative is to address hospital professional cost settlement reimbursement methodology. Currently, and it's targeted at acute care hospitals. Currently, hospital professionals are cost settled at a percentage of cost with no cost control mechanism and the amount of hospital-based settings that are subject to this cost settlement has grown substantially in recent years by over 58%. So when you look at this cost settlement process and you try to compare it to what would Medicare, for example, have paid for those services, we're paying over 170% of Medicare's value for those services on average. And that ranges widely from 100% to 300%. And so when Michelle spoke about trying to create more standardization and equity and consistency, this achieves a number of those objectives along with some cost control and aligning incentives. Next slide. Hospice services is the last one where, I mean, this is a historical rate setting methodology that just needs to be revisited, where there is one element of hospice reimbursement that for many years has been reimbursed at 123% of Medicare. So again, looking at an area where there's a misalignment across services, where we're hoping to bring that more into alignment with other Medicare benchmarks. I'll turn it back to you.
So Olivia, we'll move through these quickly in the interest of getting to questions and comments, but are a variety of sections of policy that have not undergone a rate determination process since our rate reform statute was created. So these would be up for prioritization in the future. And we can see to the next slide. Some of these services have already had partial rate determinations through our Medicare standardization initiative, but there are services without Medicare benchmarks that would also need to go through this rate determination process. Next slide, please. I won't go through details. We can review these as well, but next slide. And next slide. All right, thanks. Over to Mandy.
Thank you. So sorry we had to get through those. We just wanted to make sure that we had time for public comments. We're going to first take any comments or questions from the technical advisory panel. So please go ahead and raise your hand if you have any questions or comments. Mick.
Yeah, thank you. A lot of substance, so I'm just focusing on a couple things that really jumped out to me. One comment was exciting to hear about the intervention after first episode of psychosis. It was a while ago, but recall hearing a lot about evidence of efficacy of early intervention there in terms of preventing needs in the long term. So feels like that could be a really interesting place to kind of think about return on investment from rates or from supporting a program like that. I did have one question about the hospital-affiliated professional services. Would you mind just explaining a little bit about how you define or identify what falls under facility charges for hospitals versus what is the universe of kind of those professional charges? I know that can vary in the commercial context, so wasn't sure if there's kind of a clear way that you delineate those.
I can take a first crack at this, and recognizing this is a complex topic. There is a lot of nuance and detail to work through, but as I'll start with a very high level explainer, and we can get in more details if we need to. So typically with hospital services, the hospital can there's one claim, the facility claim that the hospital itself bills, and then there may be additional claims that are professional claims that are associated more with the providers who are actually rendering the services. So if you, I don't know, have a knee replacement surgery, for example, the hospital would submit a claim for the OR time, recovery time, any of the institutional portions of the reimbursement. But the surgeon who does that service would also submit a separate claim the anesthesiologist would submit a separate claim. The labs or pathology, if those also apply, could also be separate claims. Anybody who's been hospitalized might know that you just get a flood of claims and they never seem to end, and that's part of the dynamic here. Not all of those professional claims are considered hospital-based or provider-based. That is a classification that is dependent on a number of factors, including how those providers are enrolled with CMS, how those providers are enrolled with MaineCare. But typically that means that that provider group has some sort of ownership relationship with the hospital itself. So if a hospital or health system owns the provider group that the surgeon belongs to, then that would be considered a hospital-based claim and could be cost settled on that hospital's cost report with MaineCare.
Great.
Does that answer your question?
Yeah, it answers it enough. I know that this is complex, and we've certainly seen that on the commercial side trying to investigate claims. So that is really helpful to understand. And part of the reason that I asked was just thinking about kind of the relationship between an initiative like that, I think, and some of the work happening at the federal level around kind of site neutrality policies under Medicare, for example, where they're sort of thinking about incentives for, consolidation or that can have wider impacts on the market. So I think really helpful and an area that I know other states and the federal government are kind of thinking about. I recognize this is a different policy, but sort of thinking about that same basis of kind of regularizing charges a little bit more.
Great, Meg, thanks for that great question. And I'll just also add, David had noted that in our recent rate reform efforts, we have implemented hospital rate reform that really applies to the technical and facility side of the house and brought in greater alignment with Medicare on that side, including aligning with how Medicare treats and considers facility charges at hospital-based practices. So that is work that we've gone through, and now we're looking at the professional side. And I will just note that so as David indicated in his example, the professional services include services directly provided at the hospital. They also include professionals providing services at other locations like affiliated practices, et cetera. And right now within MaineCare, if there's an independent practice and a service is provided, then they bill off the fee schedule, and that is what they receive, and it stops there. And with the hospital-based practices, they also bill off the fee schedule. The same, they also bill off the fee schedule, but then there's additional cost settlement that is provided as, I'll call it a wraparound support that results in significantly more reimbursement, and the relationship of that reimbursement to cost depends on the location of the affiliated hospital, et cetera, but it can range from the low 80s up to 100%. But those costs themselves vary a lot, which is why we see such the variation in the percentage of Medicare, as Olivia noted.
Just reminding that that we are going to take questions from the tap first. I do see some hands raised, but just wanting to make sure we get through those tap questions and comments first. Okay, I think we're going to move on to public comments then. I just wanted, before I call on you, Kristen, I just wanted to go through the how to make a comment spiel. So in case people haven't done this before, to make a comment, please raise your virtual hand. We'll call on you in the order of hands raised. You can raise your hand by choosing participants or reactions within the controls at the bottom of your screen and selecting raise hand. Those participating by phone will select *9 to raise or lower your hand. And please leave your hand raised until you're called on. We will call on the name or telephone number of the participant and request that you unmute your line. And this request will appear for internet users as a visual prompt on your screen. And for telephone users, a recorded voice will prompt you to unmute your line by pressing *6. Once unmuted, please begin your statement or comment by stating your first and last name, your title, organization you represent, or your affiliation. For example, if you are a MaineCare member, a guardian, or other interested party. We ask that you please keep comments to 3 minutes to allow everyone the opportunity to speak. And at the conclusion of your comment, please lower your hand. And then to remind once more that for those that may have joined later, that the intent of today's session is to accept feedback on the draft schedule that we've presented for initiation in calendar year 25. We won't be able to provide details on resulting rates that may be implemented. And then at the conclusion of today's forum, we will transcribe all comments and include those in the comment summary along with any written comments received by the April 25th deadline. Okay, Kristen, go ahead. Oh.
Thank you so much. My name is Kristen Overton, and I'm the Executive Director of Skills, Inc., a nonprofit in Central Maine supporting individuals with intellectual and developmental disabilities. We provide 21, 29, and 97F services. I had a couple of comments regarding those 3 sections of MaineCare policy. I think some areas of clarification that would be really helpful are around the section 21 and 29 rates. Initially, the rates were supposed to be implemented in July of 2025 because at the same time the lifespan waiver was supposed to roll out. However, we know that the lifespan waiver has been delayed by at least a year. And so I think that it would be really helpful to know whether or not those rates are still attached together. I know that we have been waiting for those rates to be released for almost 6 to 9 months now, and it's always I appreciate that it may be in a couple of months, but we have heard it'll be released next month or a couple of months, at least 4 times now. But I guess that question is around, are those 21, 29 rates still attached to the implementation of the lifespan waiver? And then in addition to 97F, I know that in the presentation you spoke quite a bit around provider engagement around 97E, and going out to really make sure that you're understanding the services and what those unique challenges are in order to select the service model vendor. However, E and F, although they are similar, they are not the same. And I think that it's critically important that if the service planning vendor is going to be doing both at the same time, that you also reach out to 97F providers in order to make sure that you're also equally understanding what those unique differences are in the 97F providers before you determine what that service model will be, to understand that service first. So thank you so much for this opportunity.
Thank you. I think I can respond briefly. Is it okay for us to respond? Not be following our own rules. Thank you, Kristen. So I recognize that timelines have crept. It's been a fluid year with lots of different dynamics and opportunities, and that continues. As David indicated, we are working on scheduling the forum for the IDD and lifespan waiver services. So it is getting very close, and there's a lot of eagerness to be able to present. We have been having good conversations about implementation timelines. There's been recognition that while for similar services across the lifespan and the other sections of policy, we believe it's very important to have consistency in rates. However, we have had conversations recognizing that we don't necessarily need to marry implementation of everything at once. And in fact, there can be arguments for not doing that from a capacity and systems standpoint. So don't have final targets that I can talk about today, and wouldn't want to do that without odes either. But do appreciate those comments, and also thank you for your comments, and agree that feedback by PNMIF providers is very important as well. I know that there have been some efforts, and I, through my own fault, had a little disconnect in timing with Director Saucier to make sure that I had his input and updates on PNMIF before presenting today. So that is my fault, but we can follow up with more information on specifics there as well.
Thank you. I think, Mark, did you have a question?
Yes, I did have a question and a comment to tack on as well. My question is, I think that rate schedules and rate determination largely pertain to actual services, but at the same time, I would assume that administrative costs, such as processing, documentation, processing claims, etc., represents a pretty significant portion of MaineCare expenses. So I was kind of curious about, we heard a little bit about some of the efforts that other states are engaged in, and I'm curious about whether or not we've heard of other states approaching technology, and in particular, whether any states are pursuing artificial intelligence as a tool that might be used to efficiently process claims, documentation, etc., to more efficiently utilize resources in an environment where resource constraints are top of mind. So that's just something that I'm kind of curious about, whether we've heard anything from other states, or whether in the longer run, what role technology might play in terms of overall, maximizing the limited resources within MaineCare. And then I'll follow up with a comment after that.
Great, thanks, Mark. First, just to separate, I think your comment into two pieces, your question. On one side, when we're talking about reimbursement to providers for services, we do assess administrative costs to recognize they exist and they are not static, and to build that into the rates. So putting that on one side, and then I think you were really focused on the administrative costs to the Office of MaineCare Services and to the department for the work that we do. And we regularly collaborate with other states. I'm on the board of the National Association of Medicaid Directors, and they have different groups for folks who do the OIT pieces and other pieces where those conversations are really helpful. I mean, as we all know and appreciate, AI is definitely an emerging field. I myself have taken part in a couple interesting conversations with other states that have started to take advantage of AI. I've actually heard about it a little bit more on sort of the policy front than I have related to actual claims policies, or excuse me, claims systems, where you have a PHI, personal health information involved. The utilization of AI can, get a bit more complicated. And I think state OIT has some current guidelines around that as well. But as a department, I was actually just having a similar conversation on this topic yesterday with the Commissioner's Office, and I know we've got some folks who've been actively looking into opportunities. So there will be more to come on that front. Thanks for the question.
Thanks. And I just wanted to offer one other comment, which is it's really great to see all of the efforts across, a variety of different service categories. And I think making sure that rate schedules are keeping up an environment of rising cost, of course, ensures access to care for MaineCare recipients. We've also, Amanda Rector and I have also been involved in the state's Consensus Economic Forecasting Commission. And through that, we've also heard from folks within the provider community, including the Hospital Association and others. And I just wanted to highlight that I think that it's not just that this environment of rising costs affects recipients of MaineCare, but it actually affects access to care for all Mainers. Providers are under a lot of financial strain. That's what we're hearing. And so to the extent that reimbursement rates do not keep up with that environment of rising costs, that has the potential to place additional financial stress on providers more broadly and could have the potential to reduce access to care for patients of all payer types and not just MaineCare patients. So just wanted to offer those thoughts based on some of what we've been hearing from the Maine Hospital Association and a tremendous amount of financial pressure on providers that could affect Mainers more broadly. So thank you.
Thank you, Mark. Meg?
Yeah, I just wanted to respond a little bit to Mark's comments. Hearing that, I think we at the Office of Affordable Healthcare definitely, hear from folks about rising costs for care as well, and that's something that we're navigating again from that broader perspective of kind of maintaining a stable healthcare infrastructure for the state of Maine. But would just flag too, I think we're trying to think about kind of what is the fair and rational way to support those services. And I think some of that may mean certain services that may be underpaid, others that may, have more room for bring prices down, really. Because when I think about the challenges of rising costs, I think about them obviously from the family perspective too, and the challenges that presents. So just my wheels were turning a little bit on those comments and kind of wanted to flag it because I think the really understanding cost drivers and meaning input costs for healthcare providers is a tricky question and a pretty complex one. So always happy to dive into that a little bit more, but just wanted to kind of mention that because I know it's something, again, we're thinking about on the commercial price side as well.
Thank you, Meg. We are at 2:24, so if you do have any more questions, please let us know. We'd like to jump into some public comments. Don't see any of the chat with their hands raised. I'm going to go ahead and call on Pete.
Thank you, Amanda. I'm Pete Plummer from Woodford's Family Services. I want to just follow up on what Mark said a little bit. I remember the old days where communication wasn't nearly as good as it is now. And I just thank all of you. It makes our work much, much easier. My comment is related to the TFC rate increases that David was sharing with us. And the comment really is what causes anxiety for at least me, and I think many other agencies, is we see the rates, but we don't see the rules related to those rates. So to commit to the service, it makes it hard when those two aren't provided together. And that happened before in the HCT program, if you guys remember. And it's just I was wondering if there's a status of time frame when the rules would be out for that comply with those rates.
I don't know if we have a real-time status update right now, Pete, but we can follow up on that status. I know that I have reviewed and it's in process. We certainly agree that ideally there would be improved alignment, time-wise perspective between the rules and the rates, and we've got high volume of priorities that we're processing. So unfortunately, that's not always possible, but we are always striving to improve, and we can follow up with you on the specifics on that.
Yeah, no, I know you're quite busy. There's no doubt about that. But thank you for that response.
Thank you, Pete. I'm just going to share the last slide because we're coming to the end, and I want to make sure everybody has that information. Oh, I lost my controls for a second. Well, can you guys see it?
Yes, thank you.
Okay. Feel free to raise your hand during this summary, but On March 24th, the MAC rate subcommittee will meet to discuss the schedule and develop any recommendations to present to the broader MAC. And then the comment deadline for written comments will be April 25th. The email's right there. And then we will also put that in the chat. It's the ratereform.oms@maine.gov. And then the week of May 1st, we will post a summary of all comments online for the requirements and the final rate determination schedule. And then also Monday, there's a notice going out with all of the links from today's presentation and the comment deadline instructions, again, on how to submit written comments with that email linked to there. Jessica, do you see any hands raised?
No hands raised.
Okay. I think unless there's more questions, we can wrap things up. Thanks everyone for participating today. We appreciate your feedback and look forward to your written comments. Have a great day.
Thanks so much.